completed and being analyzed. And she treats thoracic and head and neck malignancies at BC. So please raise your hand during the talk if you have any questions. Otherwise, we'll have about 10 minutes at the end. Thank you.
Thanks, Inez, for the introduction. And sorry, everybody, that lunch has not arrived, but hopefully it will arrive while I'm chatting. So I had discussed with Inez what would be helpful for noon rounds and thought that it might be useful to have an update of the treatment spectrum of EGFR-directed therapies. Oops, sorry. So these are my disclosures and how I plan to mitigate bias, and want to also acknowledge that I'm on the traditional unceded territory of the Coast Salish people, which includes the Musqueam, Tsleil-Waututh, and the Squamish nations, and appreciate the opportunity to live on this land. So I thought I'd give a quick overview. In these 45 minutes, we're going to have a whirlwind tour of treatment options for EGFR mutations. We'll start talking a little bit about the types of mutations and set a little bit of common ground there, and then discuss the role of targeted therapies through the whole treatment pathways that patients can experience, from the neoadjuvant setting to the metastatic setting. And so let's first look at EGFR mutations. We know that the common mutations are exon 19 deletion and L858R, and those account for the majority of EGFR mutations we identify. And so for the rest of this talk, I will be speaking specifically about the common mutations. This is because the biology of other mutations may be a little bit different. There's EGFR exon 20 insertions and other uncommon mutations. And the behaviors of those may be different because of the location, and the location therefore defines what the protein conformation is, and then subsequently what types of agents can potentially bind to those mutations. And so as mentioned, the exon 19 deletions and L858R are the most common, about 80 to 85%, and the rest of the talk will really focus on that because I think that's where a lot of the evidence development has been. So starting at the beginning of the journey for some patients who have early stage disease, there is this consideration of neoadjuvant therapy. And we've all had great excitement about this because of the data with chemotherapy and immunotherapy changing that entire landscape. So how does that fit into EGFR mutation positive disease? And so we have some historical data on neoadjuvant TKIs followed by surgery and then platinum chemotherapy. And then there's this other question of, can we have more evidence to inform our choices around that? And we'll talk a little bit about that in the NEO-ADAURA study. So these are just a few of some of the neoadjuvant EGFR tyrosine kinase inhibitor studies in the neoadjuvant setting. And if you look on the left, you'll see that they typically had treatment with an EGFR TKI for 6 to 8 weeks. The stage varied across the different studies. They typically only enrolled the common mutations. And then if we start to look at some of the endpoints, if we look at the number of patients enrolled and the number of patients that went to surgery, we see that there is a similar drop-off to what we understand from the chemotherapy immunotherapy study. So 20–25% of patients may not actually make it to surgery after their neoadjuvant treatment. And then some studies, depending on their goalpost, looked at actually RECIST overall response rates, which varied here, as you can see, between 40 to 70%, depending on the TKI that was used. And other studies looked at pathological endpoints like complete response or major pathological response. I will say that in these studies that there were not a lot of pathological complete response. So major pathological response as defined as less than 10% of viable tumor remaining in that resected specimen. The rates were, in the range of let's say 10 to 25%. And I'll just remind you that if we go back and we look at those studies like Keynote 671, Checkmate 816, 77T, that in those studies, we were actually seeing a pathological complete response in about 25% and a major pathological response in 30 to 35%. So to me, these studies to date kind of are hitting below that. And so why might that be? So I think one thing that we should think about when we're considering neoadjuvant treatment is really kinetics of response. So how long do you have to actually give treatment to get a response? And how long do you have to give treatment to get the best response, right? Because that's ideally what you want to go into surgery with, your best response. And this is a study that looked at those kinetics in first-line osimertinib treatment. And that you can see on this graph that actually in the spider plot at 8 weeks, most patients are getting their best response, and that response is actually relatively rapid. So I think that reassures us that that time of treatment, 6 to 8 weeks, is appropriate. The second thing that you want, of course, is your depth of response. So how good is your response to therapy? Because of course, as we'll talk about shortly, some of those endpoints are actually important for predicting what outcomes might be for patients. So this is a slide actually taken from the metastatic setting. It's first-line treatment for patients who either receive osimertinib plus platinum pemetrexed or osimertinib alone. And it has the same median change in tumor in the range of about 50%. But I think what you might appreciate from just looking at the shape of the curve is actually the depth of response might look a little bit better when you add chemotherapy to osimertinib. And why is this important? Well, I think this is that connection between what we see pathologically and what the outcomes can look like for patients. So the graph on the left is Keynote 671, and this is a perioperative study where patients got chemotherapy or chemotherapy plus pembrolizumab, and then went on to surgery, so neoadjuvant treatment. I'm not really focusing on the different arms. What I wanted to focus on here is that term major pathological response. So significant shrinkage, significant reduction in the tumor viability, so less than 10% because of that treatment. And what you can see is the two curves on the top as compared to the two curves on the bottom that don't have a major pathological response shows a better event-free survival. So we have better control for those patients. And when you look at the graph on the right for Checkmate 816, this was chemo versus chemo plus nivolumab, just 3 cycles before they went to surgery. Patients on the top 2 lines who had a pathological complete response had a better overall survival than patients who did not. So telling us that the likelihood of benefit will be predicted by the opportunity to receive a major pathological response or a path CR. So what is our best strategy in EGFR mutated disease to actually achieve this? If we go back and think about the principles of EGFR tyrosine kinase inhibitors, they're predominantly cytostatic. They inhibit cell signaling. Now, because many cells can be very dependent on that cell signaling, that may result in apoptosis, but it is not primarily the role or the plan with TKIs that it is cytotoxic. So cytotoxic therapies, which are chemotherapies, the goal of that type of treatment is apoptosis. And so is there a possibility of combining these and potentially having a better opportunity to have a path CR or MPR? And so that leads to this study, NeoAdora. So this study is looking at patients who have early stage lung cancer, who have resectable disease at the get-go, and who have a common EGFR mutation. And they get randomized 1:1:1 to either placebo plus platinum doublet, osimertinib plus platinum doublet, or osimertinib alone. Then the patients go on to surgery and looking at those endpoints of MPR and PASS-CR. Subsequent adjuvant therapy can adopted as per physician discretion, and then patients are followed for event-driven outcomes. And so I think this study hopefully is going to add further to the literature that we understand so far about neoadjuvant treatments that have been predominantly explored in phase 2 studies, and will be coming to an oncology meeting this year to help define our practice in this setting. So Switching now from considering neoadjuvant treatment, which hopefully we'll get some information to help select the best treatments for our patient, let's talk a little bit about adjuvant therapy. So in this setting, we have resectable lung cancer with mutation. They go to surgery, and then they may or may not have adjuvant platinum chemotherapy as per our standards, based on multiple studies, including one led in Canada, and then the consideration of adjuvant osimertinib. And so what was the background for this approach? Again, these are some selected studies that have looked at earlier generation tyrosine kinase inhibitors and their use in this adjuvant setting. So these are essentially first generation drugs that were used for 2 years. And the one I'll just highlight at the bottom was actually a phase 3 study, the CTONG 1104 study. So common mutations, resected stage 2 to 3A, and then randomized them to 2 years of gefitinib, or cisplatin and vinorelbine for 4 cycles as per the standard chemotherapy regimen. The disease-free survival was impressive, but it did not lead to an overall survival benefit. And this is in greater detail. As you can clearly see, separation of the curve. So patients who got gefitinib had a better disease-free survival than those that received chemotherapy. But with longer follow-up, what we actually saw was the survival curves actually came together. And so the question arose as to whether this was a result of just not necessarily curing patients, but just treating them earlier rather than later in their disease process. And that's why we actually don't see an overall survival benefit. And that relates to what you see on the graph below for the patients who received chemotherapy. The vast majority of them who progressed or had evidence of recurrence went on to receive an EGFR TKI. So I think there was a little bit of skepticism heading into the data with ADAURA and the initial outcomes. So ADAURA, as you all know, was a study where patients who had completely resected lung cancer, they could receive adjuvant chemotherapy per the recommendations of their treating physician, and then they were randomized to osimertinib or placebo. They were stratified by stage, type of mutation, and race. And the treatment duration was 3 years, with the primary endpoint being disease-free survival by investigator assessment in stage 2 to 3A patients. There were obviously secondary endpoints that looked at kind of the overall population, because of course this study included 1B patients as well. And they were followed initially at 12 weeks, and then 24 weeks, and then every 24 weeks subsequently, up to 5 years. And so this study, as we all know, was positive. What I've actually presented here is the whole population, because I think that's how we've adopted into practice. The initial disease-free survival curves clearly separated with a hazard ratio of 0.2, so clear benefit to osimertinib over placebo in this population. And with longer follow-up, this showed an overall survival benefit. So I think this improvement not only helped control disease or prevent disease recurrence for patients, but also ultimately improved their outcome with a hazard ratio of 0.49 for survival. And so that, as a consequence, has been adopted into clinical practice here. I think many of us are using this quite regularly for stage 1B to 3A resected disease. Are there other, is there other data out there, or is other data coming? Absolutely. The first study is actually looking also at osimertinib, but ADAURA-2 focuses on even earlier stage disease, so 1A2 and 1A3 disease. But there's also other agents being evaluated, including, sorry, there's construction in our building, so I hope you can hear me over the drilling on my ceiling. But okay, good. So befartirtinib, icotinib, as well as almonertinib and furmonertinib. So I think I suspect that all of these data are going to further support the role of adjuvant TKIs for our patients to improve their chance of cure and improve their overall survival. So neoadjuvant, still a question, hopefully answering this year. Adjuvant, clearly something that we should be adopting into practice. What about consolidation? So this is looking at patients with unresectable stage 3 disease with EGFR mutations, who typically we treat with chemoradiotherapy. What is the role of consolidation types of treatments? Should we be thinking about immunotherapy, or is there an opportunity to consider consolidation with an EGFR TKI? So looking at our current practice, for stage 3 disease, we give chemotherapy and radiation followed by a year of adjuvant durvalumab. And as you know, durvalumab is an immune checkpoint inhibitor. And we do this on the basis of the Pacific study that showed us a significant benefit in terms of overall survival, roughly translating to about 10% at 5 years, increasing hopefully our chance of cure for these patients with some plateau of that curve towards the end. This study did allow EGFR mutations. As you know, many of the immune checkpoint inhibitor studies have excluded them, but this study did include them. And there was a post hoc analysis to look at this specific population. The question comes up, of course, because what we've learned over time is that immune checkpoint inhibitors don't tend to be very effective in EGFR mutation positive disease for a number of different reasons, sort of the fact of a driver mutation, perhaps less to mutational burden. All of those can affect the efficacy of immunotherapy. And in this very small post hoc subset analysis with 35 patients, what we see is the PFS and the OS don't necessarily appear to have much of a difference. I think it still deserves a discussion with patients because obviously we don't want to make treatment decisions solely on the basis of something with such a small subset, but I think it also fits in the larger global evidence with immune checkpoint inhibitors when you have this conversation with your patients. So is there going to be something better to think about for consolidation for our stage 3 patients? And so that brings up this study called FLORA. So this study is for patients with stage 3 unresectable lung cancer with EGFR mutations who are either going to receive concurrent chemoradiotherapy or sequential chemoradiotherapy. The requirements for the chemotherapy is at least 2 cycles of platinum-based treatment or 5 weeks of the weekly platinum therapy. And the radiotherapy is a minimum of 60 gray. Those patients will then be randomized to osimertinib or placebo, and stratification factors will include whether they got concurrent versus sequential, stage 3A versus 3B, 3C, and China versus non-China. Unlike the adjuvant studies, there isn't a defined time point for osimertinib. So patients are basically allowed to continue on osimertinib until radiologic disease progression. And then at the time of progression, the choice can be made for open label osimertinib in both groups. And this will then be followed for time to event outcomes as well as overall survival. And the press release from earlier this year suggests that there is a statistically significant and highly clinically meaningful improvement in PFS for patients in this study. And the overall survival shows a favorable trend. So we will be seeing the results of this at an oncology meeting this year as well. So something that also may potentially be practice changing for us. And this is, again, not a study that stands alone. There are other studies looking at consolidation, EGFR TKI after chemoradiotherapy, and this one is looking at olmesartan. So again, if we look back, neoadjuvant study for TKI pending, adjuvant definitely a yes, and stage 3 consolidation, well, from the press release suggesting that that is probably going to be a positive signal for us to adopt into practice. And so moving now to the metastatic disease, a place where I think most of us find ourselves when we're managing our patients. And this likely is a function of the fact that we don't really have screening programs for patients who have the disease characteristics that would typically fit to an EGFR mutation. And so we have a couple of, or I guess it'll be three first-line options at this point supported by phase 3 data. Osimertinib alone in consideration in combination with a platinum doublet, and then a novel combination, amivantamab, which we'll chat a little bit about the mechanism of action, and lazertinib, which is another third-generation EGFR TKI like osimertinib. So let's start with FLAURA because this is what has been adopted widely in practice for many years, and we're quite comfortable with this. I'll just remind you that this is the common mutations. Patients were first line, no prior treatment for their locally advanced or metastatic disease, and they went on to receive osimertinib or a first generation EGFR TKI, and the primary endpoint was PFS, with secondary endpoints, of course, including overall survival. In the study, I'll comment that baseline brain scan was not required, but if patient was known to have CNS disease, then they were followed every 6 weeks per the regular follow-up for the PFS endpoint. So if we look at this overall survival curve, so I know the primary endpoint was PFS, but I think overall survival is an even more compelling argument for adoption in practice. What we see that osimertinib was better than the first generation TKIs, and that benefit was seen really across all subgroups with a hazard ratio of 0.8, but a clear separation. And I think also for many of us that treat this disease, one of our big issue is the development of CNS disease or presentation with brain metastasis. And as I mentioned, in this study, baseline brain scans were not required, but if you did have a patient who had brain metastasis, they were followed. And so this data is maybe presented a little bit differently than some of the other studies. But we see in the full set analysis, so all patients, a progression-free survival curve is really mirrored by the progression-free survival curve in patients with CNS metastasis. So in fact, we don't see that there is a drop-off in that PFS when patients with CNS metastasis are specifically looked at. And then if we look at the other curve, the cumulative incidence of progression, what we can see is the blue curves are the osimertinib treated versus the yellow curves are the first generation TKIs. Again, osimertinib is showing us a positive signal for CNS disease control. Toxicity-wise, again, many of us are using this really quite regularly. In general, it was extremely well tolerated. So we have PFS and OS data that is beneficial. We see activity in CNS disease compared to first generation drugs, and side effect profile is really quite acceptable in that patients tolerate it very well and are able to maintain good quality of life on treatment. So let's move to some more data that's come out actually in the past year, but other treatment options in the first line setting. And so let's chat about FLAURA2. So FLAURA2, again, very similar inclusion criteria, common mutation, no prior treatment. In this study, brain scans were mandated at baseline. However, only patients who had brain metastasis were followed regularly through the duration of their treatment. And the patients who did not have brain metastasis at baseline only had a brain scan or only mandated to have a brain scan at the time of disease progression. So in this study, patients randomized to osimertinib plus a platinum doublet, and then the maintenance phase was osimertinib plus pemetrexed, or to receive osimertinib alone. And the primary endpoint was PFS by investigator assessment with regular interval scanning for those patients. And if we look at the outcomes from this study, what we see is the PFS is superior with osimertinib plus chemotherapy versus osimertinib, with a hazard ratio of 0.62 and numerically roughly a 9-month improvement in the PFS, which was seen across all subgroups in the study. When we look at the CNS data, there again is maintenance of this positive signal. So on the left is anybody who had evidence of CNS disease at the get-go, including both measurable and not resist or RANO-BM measurable disease. And you can see there is a benefit with the chemotherapy. And on the right, what we see is the curve where we actually had a RANO-BM measurable disease. And again, seeing that benefit with osimertinib plus platinum and pemetrexed. So efficacy with chemotherapy in the CNS superior to that of osimertinib alone. And there was some overall survival data. It was actually presented at ELCC earlier this year. This is preliminary. This is not statistically significant, but just to give you a flavor of what's been observed, and that is that there is a suggestion that there is benefit with a hazard ratio of 0.75, although what you see is the beginning of these curves is that there is a little bit of a crossing of that curves, and one wonders about the toxicity of osimertinib plus chemotherapy potentially impacting the shape of the curves in the beginning. Toxicity-wise, what you see on the tornado plot, just to visually represent things, is you have more side effects with osimertinib plus chemotherapy. Certainly more hematological toxicity. I think that is to be expected. But even the grade 1-2 toxicity is higher in that group. And what I would suggest to you is that if a patient has a series of grade 1-2 toxicities, cumulatively, that can affect quality of life similar to having a grade 3 toxicity. So there is definitely impact here. So we see a PFS benefit, a hint of an OS benefit. We see CNS activity compared to osimertinib, which we've seen from the FLORA study. But side effect wise, I would say that there is a little bit of a challenge here in terms of what we're asking our patients to accept with this treatment. And then on to our last phase 3 study in the first line setting, having a little bit of a different approach. This is the Mariposa study. Again, inclusion criteria are similar to what we saw in the FLORA and the FLORA-2 study. The difference with this study is that serial brain MRIs were required for all patients. And patients are randomized to amivantamab plus lazertinib versus osimertinib versus lazertinib. And again, lazertinib is another third generation EGFR TKI. And the primary endpoint was PFS. And just to give you a little bit of background on amivantamab, bringing in a new class of drugs, I think, than what we're traditionally using in clinic. It is an EGFR MET bispecific antibody, so it actually binds both. And how this can potentially inhibit or prevent resistance or improve outcomes is that it promotes degradation of the receptor, so then you can't have as much stimulation. Because it is an antibody, there is some immune cell directed activity. And then of course, it can interfere with binding of the ligand and in that way also interfere with cell signaling. So in the study, when we're looking at the outcomes, this is really these outcomes that I'm showing you are looking at that combination. So a bispecific antibody plus a third generation EGFR TKI versus our standard osimertinib. And we look at this primary endpoint for PFS, again, a positive signal seen across most of the population, regardless of their baseline characteristic. So again, a positive signal over our standard osimertinib treatment. And in this study, as mentioned, MRIs were mandated through the course of the study. And we see that PFS benefit exists in patients with and without brain metastasis. That PFS benefit is maintained. But similar to the FLORA-2 study, we run into issues with toxicity. The tornado plot, as you see, certainly more toxicities associated with the amivantamab plus lazertinib, as they're both affecting EGFR. You see more of those EGFR-related toxicities in terms of rash and diarrhea, skin-related toxicities. But the other toxicity of significance is actually venous thromboembolism. So that occurred in 37% of patients on the amivantamab lazertinib versus 9% in the osimertinib. So this toxicity was significant and higher, to the extent that, you know, some articles have suggested maybe these patients who get amivantamab, lazertinib actually need to be on some type of anticoagulation type of therapy to reduce the risk, although others have argued that that is not an evidence-based recommendation. And so are we subjecting our patients to other risks if we pursue this treatment? So we've got 3 potential treatment options. We've got osimertinib, our standard, we're currently using it, but there's also the option of osimertinib plus chemotherapy or amivantamab plus lazertinib, which have shown us better outcomes in terms of PFS at this date, at any rate, than osimertinib, but at the cost of increased toxicity. So kind of how do you choose? What are the kinds of things that we need to think about as we have these discussions with our patients? These are just some aspects for consideration. You know, I think when we look at outcomes like PFS, OS, CNS, PFS, these are really important. And however, the importance of these can vary depending on the patient and their particular outcomes and where they are in their disease trajectory. But I think we also have to consider toxicity, and the toxicity rates you can clearly see are higher, and discontinuation rates are higher with combination therapies. And then we also need to think about, how are you giving this treatment? What are the impacts in terms of quality of life for these patients? Because osimertinib is oral. Osimertinib plus the chemotherapy is oral plus IV every 3 weeks. And the amivantamab plus lazertinib is oral plus IV every 2 weeks. So another consideration in terms of impacts for patients. And so this is data actually from the New England Journal editorial by Dr. Wu on FLAURA2. And what they did here was they asked patients, their family members, and treating physicians, based on an improvement in progression-free survival by 9 months, what would your preference be? Would it be monotherapy, so just oral treatment, or combination, oral plus chemotherapy? And you'll see in B, a lot of the patients had actually prior targeted therapy and chemotherapy when they answered the question. So they had their own experience, and their family members, their own experience of what that looked like. And what you see on the graph in A is that actually 73 or roughly 75% of patients, their family members, and clinicians actually selected monotherapy. And I think then we have to take that, we've got our evidence, but we also have to look at the patient journey and their experience and our own clinical expertise, and sort of thinking about, how do you apply the data into clinical practice and put all that together when we're offering these treatments to our patients? Because not all therapies are necessarily the best for our patients, even if we are seeing these positive signals, because we need to weigh in other really important factors for our patients. And another potential way of using our treatments is actually going, okay, well, can we use a risk-adapted strategy? And so in this study that is ongoing, patients who have EGFR mutations are getting ctDNA done at the beginning, starting osimertinib, and then reassessing with ctDNA to see kind of what that response is. And so for patients who don't shed ctDNA, it's probably not, this study is not informative, but those patients who do shed ctDNA, there's a randomization to osimertinib versus osimertinib plus chemotherapy to see if treatment intensification for those patients may be the way to go. And so I think this study is going to be very interesting and hopefully give us a little bit more help figuring out the best way to treat our patients. So moving now, we've got options in our first line setting to really think about. What about beyond first line? So after targeted therapy, and I took some license here and really kind of looked at our treatment as it stands, what we have now, and what we have now in the first line is osimertinib. And so everything is following subsequently. And our typical next line treatment has been platinum doublet, but there's been data that's come out looking at platinum doublet again with that amivantamab agent, Mariposa 2. There's been a series of phase 2 studies, which I'll mention. But we also learned what we should not do. And so we have Checkmate 722 and Keynote 789, where patients with EGFR mutations, progression after osimertinib, got randomized to platinum doublet versus platinum doublet plus immunotherapy, nivolumab and pembrolizumab respectively. And this did not show a benefit in that population. So adding immunotherapy to standard platinum doublet is not advantageous for our patients. We expose them to toxicity and we don't get any extra benefit from it. So at least from that perspective, we can eliminate that and sort of sits with all the data that we know to date anyways about EGFR mutations and immunotherapy. So let's explore these second line options for our patients. And our second line options are really kind of directed by some extent to what we think our resistance mechanisms are to first line treatment. You'll see that 40 to 50% of the time, we have no idea. Just don't know what that resistance mechanism is. 15% of the time, we have transformation. So that's where we see transformation to small cell or squamous cell carcinoma. Then our next block is really looking at on-target effects, so things that are upregulation of EGFR, further mutations in EGFR. And then the rest of the pie is actually off-target effects, so upregulation potentially of other pathways, of cell cycle pathways, of which you'll see a significant chunk of that is actually related to MET and MET amplification. And so, as we talked about before, amivantamab is a bispecific antibody to MET and EGFR. So perhaps this is a good way to target some of that resistance from osimertinib. So this is an unselected study, so you did not have to have any changes in MET documented. Basically, you had to have progression after osimertinib, and then patients were randomized to amivantamab, lazertinib, and chemo, or chemotherapy alone as our current standard, or amivantamab plus chemotherapy, with the primary endpoint, dual primary endpoints being PFS in that for treatment, the ami, lazertinib plus platinum and pemetrexed versus chemotherapy, and then amivantamab plus chemotherapy versus chemotherapy as well. And so that primary endpoint of PFS showed that actually the combinations were superior to chemotherapy in this second line setting, with hazard ratio of 0.48 and 0.44 respectively, suggesting that outcomes are better for patients with the combination, and not actually that much additional gain by adding the third generation TKI lazertinib to this regimen. And that benefit was actually seen intracranially as well. So again, this is a study that mandated baseline and ongoing brain scans. And part of the rationale for including lazertinib into the combination was for the hope for CNS protection. But in fact, that was achieved with the amivantamab chemotherapy anyways. And it's not exactly clear why, because we don't think that it crosses the blood-brain barrier. It's a pretty big molecule. So it is actually not a direct effect, but an indirect effect that is actually enabling intracranial PFS. The early interim survival, the follow-up wasn't long enough, so I don't know that we conclude very much from this yet, and we need a little bit more data to understand what this impact is going to be for our patients. But when we look at adverse events, similar to the Mariposa 1 study, what we do see is that there is increased toxicity when we add more agents. I think that happens across any kind of treatment that we actually look at. What we do see is that there are more EGFR-related toxicities because of that amivantamab and amivantamab lazertinib targeting the EGFR pathways. What we also see is there was increased venous thromboembolism in the study as well. It's sort of down here in the lower part, 5% with chemotherapy, 10% with amivantamab plus chemotherapy, and again, 22% with amivantamab, lazertinib, chemotherapy. So certainly higher risk of toxicity that has been observed there to be able to gain that progression-free survival in improvement over chemotherapy alone. But that study was done without actually a biomarker for MET. And so is there something that can help us direct our therapy a little bit better? And so there are different biomarkers that have been looked at for MET amplification. One is copy number gain. So that's really, we're looking at FISH and we're saying, okay, is there 5 or more copies of MET? Or is the ratio between MET and CEP7, which is the centromere on chromosome 7, where MET is higher than 2? Or should we be looking at immunohistochemistry? So is there increased MET expression? And so we got a few different phase 2 studies that have had selected populations for MET that give us, I think, some hope for using this pathway in osimertinib resistance. And I'll just go through these very briefly. This is Insight 2 that looked at tepotinib, which, as many of us know, is a MET exon 14 skip agent. Sorry. Plus osimertinib. In this, patients had to have MET copy number gain of greater than 5 or a MET CEP7 ratio greater than 2 to participate. And what we see is that the combination of these therapies has a response rate of 54% in patients who have progressed on osimertinib. So that's giving us, I think, a potential positive signal that, similar to Mariposa, using MET as a targeting mechanism is something to consider moving forward. There's also the Teliso-V study. Teliso-V is a MET antibody drug conjugate, again, looked at in patients who progressed on osimertinib. For this population, patients had to have immunochemistry 3+, greater than 25% of cells to be allowed to enroll in this study. And again, when we see this combination, we see that the response rate is 53% in patients who've already progressed on osimertinib. So I think a positive signal here. And another option is savolitinib with osimertinib, again, targeting MET. In this study, patients were selected by overexpression by immunohistochemistry or by copy number gain by FISH greater than 5, again, showing us a good response rate. And in this study, they also looked at subgroups of patients. So if you were a very high MET expressor, if you had a very high copy number gain, did that make a difference? And there did appear to be some relevance with that biomarker, with a higher response rate seen in that subset of patients. And as a result, the study has gone on to phase 3 Saffron study, but looking again at that very specific high expressing population. Oops, sorry. So, and then I just have one quick slide on what do we do after second line. So we've got our first line osimertinib as our standard of care. We've been using platinum doublet as our second line. What do we do in the third line setting? Well, we have our standard docetaxel, but we also have a couple of studies that suggest maybe we're going to be able to take advantage of antibody drug conjugates. I'll remind you, an antibody drug conjugate is an antibody directed against a certain protein with a linker that is attached to a chemotherapy drug. And the plan is that that antibody is going to go where the tumor cells are to limit that chemotherapy toxicity more specifically in that area, and also kind of have that antibody effect as well. So we've got a couple studies in that space. These are phase 2 studies. The first one is TROPION-Lung5 that looked at datopotamab deruxtecan. The target was TROP. The population for this study was actually just actual genomic alterations, but the majority of them, 78, were actually EGFR. And it was after targeted therapy and chemotherapy and had a response rate of 44% with a median PFS of 5.8 months. The second study is the HERTHENA study, HERTHENA-Lung1 study, which looked at patritumab deruxtecan, which is a HER3, the antibodies against HER3, specifically in the EGFR mutation positive patients with prior targeted therapy and chemotherapy with a response rate of 30% and a median PFS of 5.5 months. So I think potentially options here for ADCs to take a role in that third line treatment setting for our patients. So I think in that whirlwind tour of the spectrum across neoadjuvant to third-line metastatic disease, that really over the past decade or so, there's been a lot of drug development, a lot of treatment options that are coming to the fore. We certainly are looking forward to the neoadjuvant data coming out this year. Adjuvant is firmly adopted in our practice. Consolidation data also to come out this year that may change our practice. And then we have good first line and second line treatment options, and hopefully some third line treatment options to come for our patients. So the advances, as mentioned, I think are great. I think we have lots of options for our patients, and there are upcoming phase 3 studies that are going to help define our practice further. I think decision-making around first-line treatment is really going to depend on patient attributes and their preferences around therapies. And as we learn more about osimertinib resistance mechanisms, that will help define and better select patients for next-line therapies. And so with that, I will conclude. Thank you, and take any questions.
Thank you so much, Cheryl. That was really informative. Does anybody have any questions right off the bat? Feel free to speak. Maybe while people are thinking of questions. So I guess the FLORA-2 came out a few months ago. I'm just wondering, you know, the results are positive. Obviously, the concern is around side effects. Notwithstanding approvals and things like that, is there a certain patient or patient population that you would have in mind to treat with the combined chemo EGFR?
Yeah, thanks, Inez. I think that you're right. Approvals, I think that is currently going through CADIS right now, so we will hopefully have an answer about that option soon. You know, I think the CNS data to me is really compelling. And so the population that I might favor for the combination would be younger patients who are going to be probably better able to tolerate the toxicity associated with that, and more willing to accept that toxicity for the potential benefit in disease control. And then, of course, certainly a discussion to have with patients with CNS disease because of that potential benefit there. I do think the study that Dr. Wu did, sort of asking patients, caregivers, and clinicians about their preferences, really gives us a sense of, you know, what is that balance between quality of life, being able to live your life, being able to travel, and then attachment to the chemo room to actually get those benefits. So I think it is going to make our discussions in the clinic much more lengthy with our patients to kind of fully inform them about what the implications are for adopting FLORA-2 in practice.
And I think that was a great study to ask the patients, because I think we see that quite often, that they're very relieved that they don't need any chemo. So I think it's going to be a bit of a hard sell to add that on for them. Any other questions? So you mentioned at the beginning about the neoadjuvant space. And I guess with ASCO coming up, are you aware of any, I can't recall if you mentioned, are there going to be any data coming out?
So
at ASCO?
from what I understand, the NeoAdora data will be coming out sometime this year. I don't know if it's ASCO, World Lung, or ESMO, but my understanding was that there was some data to be shared around that shortly. So I don't know.
Okay.
Let's see.
We'll look out.
If anybody from AZ actually knows.
We'll definitely look out for that.
Well, thank you, Cheryl. That was a great presentation. I just want to follow up on Inez's comment about the neoadjuvant trial, because when you look at the chemo IO in the earlier stages, the progression or patients that didn't make it to surgery was 20%. That's very similar to this. Is there any explanation for that, or should we be concerned that it's that high?
You know, well, I think we'll see what the neo ADAURA study will tell us about, what that is. I feel like this is the reason for multidisciplinary review of those patients, because you don't want to deny somebody an opportunity for a curative surgery. And there are probably borderline cases where sort of, your single station N2 disease, like, is that too close to the mediastinum, et cetera, because you run that risk of progression that then removes the chance of surgery. I think the other piece, however, that's a little bit sort of more favorable on the TKI side is that generally the response rates we see to that is higher than what we see with chemotherapy or chemotherapy immunotherapy, even in the metastatic sort of studies. So I think there are some things that may hopefully favor or reduce that population that don't make it to surgery, but absolutely a concern. Great. Well, thank you everybody for your attention and your time. And if you have any questions, please feel free to reach out.
Thank you so much, Cheryl. Another really informative talk, and we'll look forward to more talks with you in the future.
Thanks. Bye.